Ji, Assalamualaikum. My name is Dr. Shoukat Memon and I'm consultant nephrologist. So today in the General Club activity, we are going to discuss the topic or the article published in New England Journal of Medicine in 2020, which is not very much new, but as the topic remains a burning of nature in terms of SGL2 inhibitor. Dapagliflozin. Number of trial before have also been conducted. The gap which is filled by that dapagliflozin in the retardation or halting the progression of CKD in non-diabetic patient as well, which will be discussed more in detail about the next couple of slides. This is background of DAPA. Uh, you don't need to go through all of this as I have made it in simplified. The burden of the CKD is around 700 million around the world, and we already know the chronic kidney disease or CKD reduced quality and life expectancy. So, how to slow the progression of chronic kidney disease? Number of trials have been done since 1999, the renal protective properties of ACE inhibitor, the efficacy safety of penazopril, renal protective effect of angiotensin blocker, receptor antagonist, the sartan, losartan. So they have been successfully done, and a lot of literature available regarding the protection uh, of the ACE inhibitor air blocker. Then almost beyond 2010 until 2015, the number of the trials have been done for the SGL2 inhibitors, and the landmark trials were these which are shown in front of you, and in which we are going to discuss in detail is that the DAPA. Now, question comes: what is new in that when these trials have proved its efficacy and the safety as well? But the new things in dapagliflozin patient with chronic kidney disease is the inclusion of the non-diabetic patient as well, and that is the gap. Whether this hemodynamic effect may help preserve renal function in non-diabetic chronic kidney disease as well, which is still not very well established in previous trial. So just going in detail, just we should know a little bit about the SGL2 inhibitors mechanism, and this is in nephron. You can see this is glomerulus, the arrow over here. Then the connection of the tubules and the morphology of tubules denoted by the horizontal nature, then descending and ascending is the loop of Henle, and then the again collecting depth. So the proximal portion actually the area of the action done by the SGL2 inhibitor, which reduces the reabsorption of a number of very important electrolytes, glucose, causing the natriuresis. And glucose-induced osmodialysis and the TG feedback, which means the transglomerular feedback, which results into the constriction of the afferent arteriole and subsequently the reduction in the interglome pressure. And if we see the the ultimate effect of all of these trial is the reduction in the interglome pressure, which is normally the capillary pressure lies into this glome is 45 to 50, a bit higher than other capillaries in the body. So finally, in reduction of that interglome pressure leads to the somehow in the protection of the chronic kidney disease progression. The progression's factors are the most important factors are the underlying disease or the cause of the CKD, along with the coexisting medical conditions. The more the number of the coexisting medical condition, the lesser would be the prognosis or the more chances of the CKD progression, and of course the how the patients adhere to the recommended treatment plan, including lifestyle. So these factors are mainly determining the progression and how can we retard through the actual drugs. So we are here to talk about that. Now, how to slow CKD progress. Uh, ACE inhibitor, error blocker slow the progression, and mainly the evidence is found into the diabetic type 2 patients. SGL2 inhibitor the favors cardiovascular renal outcome, evidence type 2 diabetic mellitus, but that is independent of the glucose lowering effect. In nutshell, we can understand. Then we will go a bit more detail. If you see in the left side of this picture, then the start with the trials specification like it's multi-centric, almost 400 centers have been involved into 21 countries with the total target population 4,300, and all of them are, the majority of them are the diabetic, but almost 30% were without the diabetes and age for more than 18 years with the CKD stage of 2 to 4 almost, 25 to 75 is a GFR. All of them were proteinuria somehow, more than 200 milligram per gram, and the exclusion were the polycystic kidney disease, lupus, NCA, and type 1 diabetes. So these were excluded, and the ratio of intervention of DAPA with the placebo is 1 to 1, and the total designated period of 45 months. But after two and some months, 2 years and some months, uh, the trial was stopped because of clear-cut efficacy. And the primary outcome which were to be seen were the declining of the GFR. Here you can see in the extreme right side, 50% or more than 50% are a requirement of the dialysis are GFR less than 15, and renal and cardiovascular death were the primary outcome. Methodology very important to understand for a very good trial. It should be the randomized, and randomization again should not be simple, but here the randomization was done through the box method, which is standardized method, and neither the drug taker nor the giver knows, so that's called as double blind, and 1:1 ratio of the drug with the placebo is called as placebo control, and so many centers of different countries, also multi-centric. So all of these things entails a trial is standard one, and we already discussed that. This is 21 countries have been included with the duration of 2017 to 2020. Some technical aspects or in this slide where the statistician come to help, and finally the sample size which was uh, done or set was 2214 in either arm, in exposed as well as non-exposed, and total max 4428. Already discussed all our adult type 2 diabetes, without type 2 diabetes, CKD almost 2 to 4, albumin to creatinine ratio, yes, they were albumin urea, and they were on stable maximum tolerable dose of ACE inhibitor or AR blocker for at least 4 weeks. These are the four inclusion area and exclusion already discussed. Um, so I don't go into detail of that. This is important slide that showing the timeline and both of the arms, the top arm and the placebo arm, and this is timeline after the enrollment randomization. The first visit at the 14th day means 2 weeks, then 2 months, then the gap of the 4 month each till there is the common study endpoint, and finally the study closure visit. So each visit, the vital signs and the sampling of blood and urine were taken. Adverse events were noted, which we will discuss in subsequent slides, and the concomitant therapies and the adherence of the drugs were taken in account. Primary outcome we have already discussed to emphasize it. Either one of these A, B, C means declining of the GFR more than 50% or onset of kidney failure, uh, defined as a maintenance hemodialysis for at least 28 days, or kidney transplantation or GFR less than 15. So either of any of them is the primary outcome, along with the death from kidney or cardiovascular outcome. And in the secondary outcome, almost the same, but a subtle difference in the first outcome. Like you can see, the 50% declining GFR, kidney failure, and death from kidney disease only, not including cardiovascular, which was seen into here in the primary outcome that showed death from not only kidney but cardiovascular. But here a subtle difference of no, not inclusion of the cardiovascular, but the second point is different. The composite cardiovascular endpoint defined as the hospitalization for heart failure or cardiovascular death and death from any cause. And the question comes, okay, why do we set the secondary outcome? So as the study is very much not only time consuming but a lot of efforts, the expenditure is incurred in that. So it comes up with a number of other the results along with the primary outcome. So to make the best use of the study, secondary outcome are set. Intention tree analysis includes all those which are enrolled at the time of the enrollment or the time of the beginning, irrespective of some of them who do not follow or cannot follow due to the any issue, or either they die or either they do not take the medication and could not follow due to adverse effects, whatever the reason which have halted their follow-up, but they all include in the final analysis that called an intention to treat analysis. And how is it different from per protocol analysis, where only the finally remaining sample size which just completed the trial analysis done on those is per protocol analysis. So, but more weightage is given to the intention to treat analysis. How ethical concern were addressed? Very important question. As that was industry sponsors trial AstraZeneca, but the oversight body, the executive committee of the 9 academic members, 2 non-voting members were there. Center local ethical committee at each trial site were there, and there was informed consent, independent data safety and monitoring committees. All of them show ethically the trial was sound. Regarding the adverse events, the mainly the volume depletion renal events, major hypoglycemia, bone fracture, amputation, and some of the diabetic ketoacidosis or foreign gangrene were taken into account, which we will see in next couple of slides too. Starting with this baseline characteristics, where you can see on the left side the different variables in both of the arms, the DAPA arm and placebo arm, almost comparable. You can see the age 61.8 plus minus 12, 61.9 plus minus. So very much comparable age, not only the age, but each variable you can see over here and sub variable. So they are quite comparable, which show how strong the study is going to, how robust the results should be, followed with the very important aspect of validating the internal validity. And when there's a good internal validity, it shows it ensures the goodness of the external validity as well. So this is a very important slide from that perspective. Now, moving, like see, yes. Now, if you see in this graph, this is the survival analysis graph of the Kaplan-Meier, where horizontal line you can see the actually the duration, and the vertical line shows the risk, and the risk is more suggested by the placebo group than the DAPA, and with the hazard ratio of 0.61, and we know the hazard ratio lesser than the 1 favors the intervention group, which is the DAPA group. So here the 0.39 risk reduction, we can say, if we take the one which is the neutral one, when we say when the hazard ratio is 1, which is suggestive of no benefit of the intervention group, and here the intervention group is DAPA, but it's lesser than 1. The more lesser than the word lesser than the one that it suggests the uh, more effective on part of that drug, and subsequently it would show, okay, how good the drug is in terms of number needs to treat as well, which we will discuss later on. Here the renal specific composite outcome has a ratio 0.56, so again favor the intervention, and the subsequent other the outcome measures, composite outcome of the death and cardiovascular causes are hospitalization for the heart failure, again 0.71, very good, and 0.69. So from every aspect the intervention group is very much on the safer side. This is good slide, which is the forest chart, and how to read that, not very difficult. Again, on the left side is the variables, and the first one to the left side is the DAPA arm and the placebo arm. You can see the all the participant who had the due to the intervention, what happened, the primary outcome were met. 197 out of this number, uh, 201,000 of 2,152, and similar out of that 2,152, the number of the primary outcome were seen 312. So more in the placebo. The primary outcome, as we knew, the primary outcome is the declining of 50% GFR, or the requirement of dialysis, or all-cause mortality. So from every respect, you can see the more numbers have been seen in this placebo group, and that is again verified with this hazard ratio we have already shown is lesser than 1, favoring that intervention group. And if you see these horizontal lines, which are again on the left side of this middle line, which is neutral, showing the 1 hazard ratio. We already discussed the 1 is showing almost neutrality, neither sides on benefit, means the intervention group is not benefited at all when the this horizontal line crosses that midline. But here almost all the lines on the left side, so suggest of the goodness of that intervention group. And the width of that horizontal line is actually, the more the width is saying, is suggestive of not goodness of that study, as the sample size not adequate. In this case, sample size very small, so that's more wider, and the box in between is actually the effect size. The bigger the box, again favors the intervention or effect size of that study. Okay, so after that, the primary outcome as well as the adverse events. Some of the adverse events were on more on the intervention side. Some of them are on the placebo side, but as the efficacy were very much robust in the study, you can see the number of the events in the placebo are more clear cut, more than the intervention group already discussed. So the trial could not completed because of that clear cut efficacy. Okay, then we come to another slide, which is when we apply the results of the subgroup analysis on then the type 2 diabetes, the hazard ratio of primary outcome when comparing DAPA with the placebo was 0.64. That's good, but that's even better in participant without 2 diabetes. The hazard ratio was 0.50. So we can say The DAPA may be particularly beneficial for non-diabetic patients in this study. NNT, very important concept number needs to treat, which has been taken with the inclusion of this concept, even in control group and even in treatment group. How is it calculated like that? The absolute relative risk, then the subtracting the event from the control group, then it came out to be the 5.3 when its decimal form is 0.053, and the number needs to is formula 1 upon ARR, and when you do calculate, it comes out to 18.86. The 19 comes out to as a number needs to treat. It's quite a good number. When you treat 19 patients, then the 20th patient is going to get benefits, not a bad number. Mortality, death occurred in one participant, which is 4.7% DAPA group, and 146 in the placebo group with 6.8%. So again, the very good hazard ratio 0.69. So we can say the DAPA was 31% less likely to die compared to taking placebo. And to see the validity of study, these are the question, and they were addressed with the answer of these questions. Randomization, yes, it was randomized, certified, computer based, double blinding was there, placebo control ratio 1 to 1, baseline characteristic very much comparable, intention to treat analysis was done. So all of these things suggest to a very good trial and very efficacious, and hopefully you have learned a lot of things as I myself learned a lot from that understanding that trial. Thank you very much and take care.